Good afternoon. I'm Dr. John Davison, Chief Executive Officer of the Trust, and I'm glad you're able to join us today for the fifth webinar in our ABPP webinar series. I want to take a second to acknowledge ABPP and thank them for the great work we've accomplished together since our partnership began in December 2021. Today's webinar is being presented by Dr. Melanie Wilcox. Dr. Wilcox is an incoming associate professor in the Counseling Psychology PhD program at the University of Albany, where she also earned her PhD in 2015. Her research focuses on culturally and structurally responsive psychotherapy and training, including clinical supervision, racial and socioeconomic inequity in higher education, and whiteness, anti-racism, and social justice more broadly. She has co-authored over 35 peer-reviewed articles in these areas and is currently president-elect of APA Division 17. I hope everyone learns a lot over the next 2 hours. Please join me in welcoming Dr. Melanie Wilcox.
Wonderful. Thank you so much. Thanks for having me, and thanks to everyone for being here today. I'm going to share my screen and hopefully folks can see my slides here. So I'm really excited to be joining you all today to talk about culturally and structurally responsive care, which is what my work centers on and something that I am really passionate about. I'll spare you walking back through more details about my bio. I think you've heard plenty enough, but I'm joining you today from upstate New York after being down south for about 10 years. So very glad to be back in New York. I also developed a deep love for the South through that as well. In addition to my academic work, I do work part-time in private practice because I can't let go of practice. I love it as well. So our objectives today are to define and describe the difference between the multicultural competence model and the multicultural orientation model, and to define and describe structural competencies and their importance to psychotherapy and to clinical supervision. So I have broken this up into 3 parts. The first I often call back to basics for possibly the first time, which will probably make a little bit more sense once we get to that part. Movements in culturally responsive care, and then moving from a multicultural competence model to multicultural orientation and structural competencies. First, I want you to think about what comes up for you as you see and hear these words: racism, white supremacy, privilege, oppression, intersectionality, intersectional oppression, gendered racism, microaggressions, structural racism. Regardless of what specific words or feelings might come up for folks, typically it's not a whole lot of warm and fuzzy feelings. Often it's a lot of negative emotions, anxiety, worry, maybe sometimes other forms of negative affect. It tends to not be thoughts or feelings that are easy. And why is it so difficult for us to hear these words and to approach these topics? There are a lot of reasons for it, but given that it is often so difficult for us to talk about these topics, I want us to consider approaching today's content from a place of critical self-compassion, which I know may sound like an oxymoron, but not necessarily. Critical self-compassion is based in multicultural orientation and structural competence, because cultural and structural humility is core to everything that we're going to be discussing. And what these essentially mean is that we, as individuals and our professions, we can't possibly know everything. We can't know others' experiences. We can't know things that we were never taught. And worse yet, we often can't know what we don't know. So critical self-compassion asks us to have care and patience for ourselves and the reactions that we might be having when difficult topics come up, while simultaneously balancing that with holding ourselves accountable for our reactions, having some curiosity from where those reactions might come from and to be able to observe them, and allow ourselves to feel what we're feeling, because we feel what we feel and our feelings are valid, without necessarily reacting or acting out those feelings toward others. So my asks of you in this are that we engage from a place of mutual respect, listen to understand rather than listening to respond. Remember that everyone's zone of proximal development is different, my own included. Be mindful of impact regardless of intent. Expect imperfection, it's all we have access to. And if you feel a strong reaction, exercise critical self-compassion. So with that, we'll take a moment to take a deep breath. And get back to basics, possibly for the first time. And I say for the first time because my experience has been that the way that we talk about anything related to diversity, social justice, sometimes the imprecision in our language can lead us astray and lead to some of the very activation that can be a barrier in these conversations. On the flip side, sometimes we label things and we talk about things in a way that make us comfortable, but that don't necessarily directly address the problem. And whenever I'm speaking on this topic or I'm thinking about issues of social and racial justice and culturally and structurally responsive care, I think about this quote from Dr. Tama Bryant from a Racial Equity Summit in 2022. She was then, I think, president-elect of the APA, now past president of the APA. And she said, when we lack courage in our language, our actions will lack courage. I think about this a lot. And I think not only about the implications of our language on our actions, but as a therapist, what our language signifies to other people, right? I learned early on in my career as a student, some of the most important lessons I learned were that if you can't talk about something in therapy, then where can you talk about it? Right? We as therapists and clinical supervisors too are supposed to be the people who can talk about anything and without mincing our words or downplaying things in our language. And so we know in other domains of our work that if we soften things, if we don't talk about things directly for what they are, it signifies something to our clients or our supervisees, and that signal has an impact. And so, to me, this just further speaks to the importance of precision in our language and talking about the things that we mean to talk about. To that point, APA is finally reimagining its approach to and understanding of racism. I think to the surprise of a lot of psychologists, psychology is often among the last to arrive on this. When I was a grad student, I was much more, starry-eyed, I guess, about what it would mean to join the profession. And I thought psychology was at like the leading edge of a lot of these things. I've since learned that that's not always necessarily true. And so for APA to be at this place where we are naming racism for what it is, as I'll show you in a moment, adopting policy resolutions to call it what it is and to be clear about our commitments, that's a big deal. It says something about where we are and where the rest of us need to be. So, this jump in commitment, I think, really turbocharged in 2020. We see the statement here at the time from then President Dr. Sandy Shulman saying we are living in a racism pandemic. And this idea that racism is a public health issue is not something that's unique to psychology or, one of Mel's crazy ideas, but rather something that is a point of clarity amongst a lot of our peer professions. Here in front of you, you have statements from the American Public Health Association, the American Medical Association, the Centers for Disease Control, in addition to APA, and this is just a small sampling, that make clear that racism is a public health issue and that don't mince words in our naming of it as such. The American Psychological Association has further committed to addressing systemic racism and clarifying psychology's role in the development and maintenance of systems of racism and racial hierarchy in the US, and what we should do about it, given our role and our past participation. So in February of 2021, APA adopted the resolution on harnessing psychology to combat racism, adopting a uniform definition and understanding. Got to start with precision in the language, right? And so there are a lot of important things in this resolution, but that includes this statement. Therefore, be it resolved that psychologists should consider the following 4 levels of racism, starting first and foremost with the structural, followed by the institutional, and then we get to the things that psychologists are usually pretty good at, the interpersonal and the internalized. But we need to understand those in the context of the institutional and the structural. That February 2021 resolution was followed by a whole series of council resolutions, and this work continues. This included in October of 2021 an apology by APA to people of color for our role in developing and maintaining those systems of racial hierarchy. And less known is a companion document to that apology, which was a commissioned historical chronology outlining psychology's contributions to systemic and structural racism and white supremacy. If anything is required reading as a psychologist, I think that document needs to be it. In my private practice, I'm an assessment psychologist in addition to doing therapy. I'm often tapped as the person to teach assessment, especially cognitive assessment. And there are a lot of things that psychology needs to account for in our past history, but more than anything else, that document reads like a history of cognitive assessment. And we all need to know that history and be well versed in it. So please don't sleep on that historical chronology document. Additional resolutions from October 21 include the role of psychology and APA in dismantling systemic racism against people of color in the US, and the APA resolution on advancing health equity in psychology. But this work didn't stop in 2021. Here, as just one example, is the resolution I had the privilege to be a part of, which was from last summer. Actually, I adopted at last year's convention, the APA policy statement on equitable and inclusive student admissions in higher education, a direct response to the Supreme Court decision on affirmative action. And so we're clearly at a point where the APA and the profession is clear about what our commitments are in addressing and uprooting racism. And so, it's great that APA is in that place. It's great that pockets of the profession are in that place, but not everyone everywhere is necessarily on the same page or even aware of some of these advancements. It's why I do the work that I do, like meeting with you all here today. And so let's look, for example, what training often looks like, because that is the majority of where students, eventually professionals, get their socialization into the profession. And so in particular, whereas in social justice work and in anti-racism work, we are often trying to address downstream problems caused by upstream systemic and structural issues. I would argue that even if all you're doing is individual psychotherapy, which is incredibly important, that is still directly dealing with downstream problems that are caused by upstream, which is to say systemic and structural issues. A lot of mental health and vocational issues that we seek to treat have upstream causes or contributors. So whereas in our work, we're often dealing with downstream issues caused by upstream problems, a lot of research, my own and others, has shown that professional psychology training and healthcare training more broadly tend to focus almost exclusively on individual difference models, the bottom half of that definition of racism, ignoring the contributors that come from upstream. So true social justice intervention at any level, again, whether you are writing public policy or you are working with individuals and families hour after hour in psychotherapy or any type of work or combination in between, true social justice intervention requires the ability to conceptualize structurally. But we can't conceptualize structurally unless we learn deeply about systems, structures, and history. The way that we often understand culture is a helpful starting place and also has its limitations. Hays addressing model is a great example of this. It has serious limitations, but it nonetheless can be a helpful starting point. So typically this compels us to think about identity and think about identity in terms of domains including age, disability in its various forms, religion, ethnicity, sexual orientation, social class and socioeconomic status, indigenous heritage. So here in the US, that would be Native Americans, nationality and citizenship, and gender, covering both sexism as experienced by women and cissexism as experienced by trans and gender non-binary individuals. But even in precision in our language, a really crucial part of making this model useful is something that's too often dropped, which is that this isn't just going down a list and counting up your privilege points. We have to understand on each dimension who has the power to oppress. And this is not binary either, who has the closest proximity to power. And I think that when we talk about privilege, this is probably one of the most misunderstood concepts that we have in DEI work. And as a result, my experience has been that what people often hear when we start talking about privilege is you had or you have it easy. And this is not what we are meaning to say at all when we're talking about privilege. This is Another reason why I think I'm a good messenger, certainly a passionate messenger about our more nuanced understanding of these concepts. I was just working on my fellows address for convention right before this, and a big part of that is talking about my path to counseling psychology and the ways in which it very much was not easy. It was not easy, but the fact that I'm a white person dealing with the barriers that I dealt with meant that I did have it a little bit easier because I didn't have to contend with the barriers of racism. Privilege is better understood as the absence of barriers based on a particular dimension or domain. So, privilege isn't saying that I had a super easy life because I'm a white person. It's saying that my life wasn't made harder by having to contend with contemporary and historical racism. And that's a really important difference. Another myth is that privilege is additive. You either have it or you don't on certain dimensions. And kind of going down that Hayes addressing model, you can essentially add for yourself a kind of privilege score. The common exercise or exercise that used to be common, the privilege walk, is a great example of this kind of line of thinking. But this too continues to sort of add to the mythology and some of the defensiveness or things that don't feel good about this concept of privilege. And it really kind of misses the mark. And to understand where and how this misses the mark, we have to recognize the ways in which the misunderstanding of privilege and the misunderstanding of intersectionality are deeply intertwined. Grzanka argues that intersectionality can really be understood as a lens or a frame through which we can look at or analyze a situation, a critical framework for conceptualizing human experience, especially power and inequity, and an approach for understanding multiple social identities and how they function in contextualized systems of inequity. In practical terms, it's a lens through which to recognize that privilege and oppression are no more additive than simply adding sodium and chloride and it just being the two elements added together. Once sodium and chloride are bonded, they become an entirely new substance that can't be separated into its parts, table salt, right? And so we start with these two elements, but they become something more than the sum of its parts once we add these together. And it's so important that we understand intersectionality in that way. Let's add a final layer of complexity to this privilege construct. Will Liu argues that from a Macintosh perspective, and most of us who received any kind of education and training on privilege probably read the original Peggy Macintosh documents and learned it from that framework. From the original Macintosh perspective, privilege is everywhere, which is to say we all have at least some. But in reality, Will Liu argues, it's scarce, belonging only to those at the very top. He notes that if everyone had privilege, it would be a right, and that institutions work in concert to regulate, legitimize, and afford privileges to individuals in certain contexts. More specifically, he defines privilege as an entitlement and unearned authority of white men, and specifically white, cisgender, heterosexual, Christian men, predominantly those who are traditionally wealthy, to engage in attitudes, beliefs, and practices in any time and any place to perpetuate the status quo of white supremacy, social and racial segregation, and systemic inequality. He argues that the manifestations of privilege that we're often talking about when we talk about folks not fitting into that definition, experiencing privilege, can really more accurately be called proxy privilege, which can be granted or taken away by power brokers when we do or do not adhere to our prescribed roles, is not portable or enduring, and often results in increased efforts on the part of the marginalized people. So white women, some people of color, lower socioeconomic status white men, to obtain and maintain that proxy privilege. So when we talk about proxy privilege being granted or taken away, for myself, if I had, unabated access to privilege, I could say anything, do anything. I could certainly stand up for racial justice in any context. I could have blue hair and I wouldn't endure consequences for those things, right? I'm breaking out of my prescribed role as a white woman by advocating for racial justice or by not fitting into the mold that I'm told that I'm supposed to look like. And I would never endure any consequences for those things in any situation if privilege were something that I owned. But the reality is that most of us are just kind of renting it, and it can be taken away at any time, and it will be taken away when we are advocating for racial and social justice. This helps keep us in line, which is to say, upholding systems of oppression. When we talk about things like the risks of doing this work or don't rock the boat, this is exactly what we're talking about. We're acknowledging implicitly that our access to privilege is actually precarious and has contingencies, and also suggests that we should take some steps to protect that privilege rather than disrupting the status quo. A couple of other really important points I think that it's crucial to cover in this work. Earlier my asks included focusing on impact over intent. And most of us know what microaggressions are at this point. And a common response to learning that one may have committed a microaggression is a focus on intent, but I didn't mean anything by it. Microaggressions are brief, everyday exchanges that send denigrating messages to people of color or people from other minoritized groups. So these are everyday and, crucially, often unintentional exchanges that, regardless of intention, convey denigration, invalidation, or even insulting messages to people of color or individuals from other minoritized backgrounds. There are three different kinds, and I think that sometimes when we think about microaggression, we are specifically thinking about micro assaults. These tend to not be unconscious. The intent of a micro assault is to harm, such as saying a racist epithet. But micro insults and micro invalidations tend to be unconscious, not always, but they tend to be unconscious. And regardless of lack of ill intent, a lot of the time, they nonetheless convey rudeness, insensitivity, or snubbing in the case of a micro insult, which can be verbal, or you the affirmative action hire, or nonverbal, something like behavioral avoidance, or micro invalidations, which exclude, negate, or nullify the psychological thoughts, feelings, or experiential reality of people of color or other minoritized individuals. So this could include things like I don't see color, or not everything is about race. This is where we come to the understanding that colorblind racial attitudes are a type of racism, because regardless of the intent, they may often come from a positively meant place. They nonetheless have the effect of negating or nullifying the experience of people of color. To say I don't see color is to say I don't see you and the reality that you experience. Crucially, these aren't called micro because their impact is small. We know from the research that their impact is actually quite profound. They're called micro because they're subtle, really easy to miss, to the point that often, even if not always, they're often beyond the offender's awareness, which often puts people in the position of potentially having to give feedback to the person who committed the racial microaggression, which can sometimes elicit some defensiveness. That is the origin of that ask on my list of asks, that we focus on impact over intent, is the recognition that whenever feedback comes up in conversations in response to a microaggression possibly having occurred, we often shift back to a defensive kind of, but I didn't mean it. Doesn't matter if we meant it or not. What matters is impact over intent. So with that foundation, going back to some of the core concepts that I think it's important that we take a more nuanced understanding of. In the context of those more nuanced understandings, let's take a look at some of the movements in culturally responsive care over the past several decades. So a number of movements in psychology dating back at least to the early 1980s, possibly going back further, have sought to address psychotherapists' readiness, or really lack thereof, to work with clients whose lives and presenting concerns are affected by their experiences of oppression. Even aside from the experiences themselves being harmful, we also know from the research that due to those experiences of oppression, and going back to that historical chronology document, some of them by our very own profession historically, some people who need psychotherapy or other mental health services won't seek it or obtain it, because there's a lot of cultural mistrust, and that cultural mistrust is fair. And so in that recognition that there's something that psychology needed to do to not only be more ready to serve diverse populations and to address the downstream effects of oppression, but to make amends for the fact that historically psychology has not been a safe place. Mental health services have not been a safe place for people of color and members of other oppressed groups, that we probably had some work to do to figure out how to do that. So, in a recent publication, some colleagues and I sort of traced back the multiple movements in cultural and structural responsiveness in psychology and mental health more broadly. And while certainly there had been writing prior to the multicultural competence articles, this really seemed to be the beginning of integrating this recognition into psychology and trying to develop models that truly provided us a roadmap for how to do better. And so, beginning with the first publication in 1982, in response to, or as part of a Division 17 presidential initiative, we had this multicultural competence movement that to this day remains the prevailing model, as I'll say a little bit more about. Multiple movements have come after that, but as I believe I come to in just a moment as well, even though we've had multiple movements since that time, a lot of these have not necessarily been integrated into our training programs. And again, our training programs are where most people get their socialization into the profession. Um, Obviously, we engage in some continuing education, just like you all are here today, but we're not immersed in it in the same way that we are in graduate school. So it really matters what we're covering in our training programs. And so we see multiple movements after the multicultural competence movement to include the social justice movement in the early to mid 2000s. I do think that's been integrated some. Same with privilege, beginning in the mid to late 2000s. There was an article before ours, Peter C. and colleagues, 2009, where they did a similar sort of review of what was happening in training programs. And their review cut off around the privilege movement. And so the movement since that Peter C. and colleagues study have included the intersectionality movement in the early to mid 2010s, understanding whiteness also in the early to mid 2010s, white allyship and critical race and critical whiteness perspectives in about the late 2010s, multicultural orientation, which I'm going to talk more about today, late 2010s to the 2020s, addressing anti-racism and anti-Black racism in the 2020s, and in particular in response to all of the racial violence that we all bore witness to in the summer of 2020, and very recently a shift toward a structural competencies model. So in the research and in our theoretical models, there's been a lot of advancements, but when it comes to our training, are we there yet? Again, research suggests that we haven't necessarily integrated a lot of those things. So looking at the multicultural competence movement specifically, first let's look at what competence even is, what it means, because I think we take the definition of this for granted a lot when we refer to the model. Competence refers to habitual and judicious use of communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflection in daily practice for the benefit of the individual and the community that we serve. Rodolfo and colleagues added that this is generally understood to mean that a professional is qualified, capable, and able to understand and do things in an appropriate and effective manner. So this model, the multicultural competence model, again, this is what most of our education, training, research, what a lot of things are still based on, is sometimes called the tripartite model, because even though it's actually meant to be this sort of 3x3 model, that's a little bit more nuanced. Typically, it gets distilled down into what you see on the top of the chart here, which is attitudes or beliefs. We often now call this awareness, knowledge, and skills. So per the original model, multicultural competence means the extent to which an individual has developed cultural awareness, obtained cultural knowledge, and acquired culturally relevant therapy skills. And so a lot of our guidelines, our research, the way that we engage in education and training is usually based specifically on this model. There is a little bit of empirical support for the multicultural competence model. There's some evidence that multicultural training leads to increased multicultural competencies, although this is overwhelmingly someone self-reporting their multicultural competence, which many have argued. It may really be saying more that multicultural training leads more to multicultural self-efficacy than it does to the actual behavior, the definition of competence. We do see some evidence that client-rated multicultural competence is related to psychotherapy process and outcome in some studies, not a lot of studies, but in some studies. Overwhelmingly, though, despite now over 40 years of research, the research evidence remains pretty scant and mixed with regard to multicultural competence. And even though there's a lot of literature on it, the majority of it remains theoretical. We have very limited psychotherapy research on the MCC model and even more limited research on multicultural training and MCC, especially where it doesn't rely on self-support. Crucially, the theorizing has never really shifted. It was developed by committee consensus, back in 1982. It was part of a Division 17 Presidential Initiative Task Force, and it was meant to be a starting point, but it never really, in terms of like the actual theorizing, evolved necessarily beyond that point. And so for quite a while now, many scholars have called for innovative theorizing as it pertains to MCC. And so this is the movements and those calls where my research was initially generated from. My early research sought to understand multicultural competence through the lens of social dominance theory. I'm not going to get into all of SDT right now. You can see the articles for a review. But some of the most important things include that taking this lens to multicultural competence, understood multicultural competence conceptually, not as a process just of learning, but also a process of unlearning. SDT explains that we are socialized with a lot of problematic cultural messages. They call these legitimizing myths, a prevailing one in the United States being the myth of meritocracy. That we are socialized with a lot of these legitimizing myths about ourselves, about others, and about the systems in which we live and work. And so also consistent with this theory and some other scholars' suggestions, this would suggest that awareness of the fact that this is operating is subordinate to or superordinate to knowledge and skills. But what I meant to set out to study kind of doesn't matter, because what I ultimately found through my dissertation study and then many other studies later is that over and over and over again in large samples, different types of samples, trainees, licensed practitioners, everybody rates themselves really high in multicultural competence, that whole multicultural self-efficacy thing. But when we ask people to do things like engage in case conceptualization, for example, they more often than not don't attend to cultural factors at all. And I'm not being hyperbolic when I say at all. The first study where I sought to compare the self-efficacy and case conceptualization, I was so struck by the overwhelming zero scores that I thought, oh my gosh, my research assistant at the time and we must have trained the coders wrong. Let's go back and do it ourselves. And so we recoded absolutely everything. And I don't think we changed a single score. And overwhelmingly, the score was zero. Even when we were like, I will give you 1 point if you will just say something that alludes to thinking about culture. Like, I'm desperate here. Give me something, anything, and I'll give you a 1. We didn't change a single score. And the modal score across multiple samples was 0, not a single mention or allusion to anything related to culture. But again, everybody rating themselves above the midpoint on multicultural competence. So, we see here that the prevailing model that our education, training, our guidelines, everything like that is based on has left some things to be desired, right? Undoubtedly, it was a crucial shift in the field to have this focus on multicultural competence. It gave us the foundations and the language to start to have these conversations and allowed us to accrue foundational knowledge to be able to launch off from. But what we find in the empirical literature is that psychotherapy outcomes haven't improved a whole lot. One major empirical finding that was pointed to early and often in the literature was that clients of color would still terminate therapy unilaterally at much higher rates than white clients. Research suggests that hasn't hugely changed. We understand a little bit more now about why and what the processes are going on, but the numbers haven't hugely changed, right? So there's still some mark that we seem to be missing in terms of doing what we set out to do, which is provide better culturally and structurally responsive care to clients of color and folks from other minoritized and oppressed backgrounds. So this is where I think multicultural orientation comes in as a crucial foundation. And certainly for me as a researcher, came at a good time because I was doing my research on multicultural competence and finding the same results over and over quant, qual, mixed methods, different types of qualitative approaches, you name it. No matter how we looked at the question, we came up with the same answer. Everybody thinks that they're super multiculturally competent. Nobody is attending to cultural or structural factors in their case conceptualization or treatment planning. So I was very much like, now what do I do? Because I kind of staked everything on that program of research. And, it also was just really tough to look at those results as someone who's genuinely passionate about culturally and structurally responsive care, to see that it might not be happening to the extent that I had hoped it was. So, around this same time, we started to see more in the literature about multicultural orientation. This research really began with cultural humility specifically in the early 2010s. You don't see multicultural orientation as a model appear in the literature until around this 2018 mark. But the empirical research on it begins with the early studies on cultural humility in psychotherapy. To be clear, cultural humility is a construct, and the empirical research on it didn't begin with psychology. If I recall right, it actually came from the medical literature, which is a parallel process that we're going to see a little bit later too. But we start seeing it ported into counseling and psychology in the early 2010s. So the theorists in psychology argue that multicultural orientation can be considered an extension of or an addition to a competence model. And I'm being very intentional with my language there when I say in addition to a competence model. And we'll get back to that in a little bit. I would argue that this is the closest to the skills component of a competence model that we've ever been able to get. In all of that previous research that I told you about on multicultural competence, the way that we measure it historically has abandoned the skills dimension altogether because we've never been able to empirically identify it. That's that develop culturally relevant skills component. We just don't have a lot of good empirical support for it. And so a lot of times when we were studying empirically, at least quantitatively, multicultural competence, we were focusing on awareness and knowledge and just jettisoned the skills component because it never seemed to show up. And I think that's because the way that we were just defining skills in that context was really kind of divorced about what we know is most important in psychotherapy from the empirical research, which is process. And so I think that because of that, this is the closest to the skills component that we've been able to get. MCO is a process model rooted in the contextual model that is described in Wampold and Imel's The Great Psychotherapy Debate. It sits on the corpus of literature that shows again and again that what matters most to psychotherapy outcome is the process, and what matters the most to process is the relationship. So MCO is really more about a way of being in psychotherapy or clinical supervision rather than something that we do in psychotherapy and supervision. And because of this right at the outset starts to better account for intersectionality because, I've been doing work in this area for 15 years now and spent a good chunk of that time teaching classes and talking to audiences in the different phases of our cultural and structural kind of understanding. And early on, before my work started shifting in this direction, I encountered a lot of overwhelm from people as soon as we started to introduce the concept of intersectionality, because understanding that I need to do some reading about working with clients of color, that I think felt manageable. Understanding that I need to do some reading on working with economically marginalized and low income clients, that I think felt manageable. But when we start layering people's complexity, right? And you start thinking about all the potential combinations when we're thinking about it from that like addressing model standpoint and thinking about it mathematically. Suddenly, the amount of literature that we feel like we need to be up on, read, stay on, like constantly be up on, in order to be competent to see any client who walks in our door feels very overwhelming. And a competency only approach does sort of suggest that, what's the alternative? Being incompetent to see a particular client, and you can't always control who's walking in your door, and we want to be able to see whoever walks in who needs help. The math on that doesn't look great, right? That ultimately means I can't possibly be competent to work with all the client populations that I need to be prepared to see. And so I saw a lot of overwhelm in response to that model. And I saw a lot of shutting down in response to the overwhelm, or a lot of giving up. Like, this isn't possible anyway, so why bother? Right. And that's obviously not great for development and training. And so when we take a more process-oriented approach, and we'll get to the knowledge components of this in a few minutes, because obviously there's still knowledge that we need. But when we start with a more process-oriented approach, it helps us get out of our heads about all those possibilities, worrying about being perfect, worrying about the exact positionality of our client, and the fact that we haven't yet read an empirical article about that exact positionality, and helps us be there with the client and meet them where they're at. So multicultural orientation is comprised of 3 pillars. I need to change this graphic because it's not really perfectly representative, because each of the pillars interacts with one another. And the center of the model is cultural humility, followed by cultural opportunities and cultural comfort. MCO is rooted in 4 assumptions. First, clients and therapists co-create cultural expressions. This is rooted in the recognition that individual therapy is a 2-person endeavor. And you might be looking at that and think, well, yeah, duh. But I think it's easy to forget that, like, we are an influence in the dynamic. You know, it's easy for our focus to be exclusion of, like, even just, for example, me being who I am, having an influence on the dynamic. What brought me to grad school in counseling psychology was a recognition that, like, I'm obviously a very white woman, and, you know, I'm committed to anti-racism work. And so, you know, recognizing that there was something that I probably needed to be doing, knowing that if a client of color walks into my office, or a student of color walks into my office, before I say a word, before I can do anything, I am representative of a legacy that doesn't necessarily represent anything good to the person who I'm charged with helping and who I very much want to help, right? So I am influential in that dynamic without even doing anything. And that is the purpose of recognizing that individual therapy is a 2-person endeavor. Really remembering that we are an influence on that dynamic, even when we don't mean to be an influence on that dynamic. And then being intentional about our influence on that dynamic to the extent that we can be. MCO, as I've mentioned, is considered a way of being rather than a way of doing something in psychotherapy. And it recognizes that cultural processes, like cultural humility, are critical to connecting with clients regarding their most salient identities and positionality. Crucially to what I was just saying about the competence versus process model, being strong in MCO, we argue, motivates therapists to learn new things about their clients' perspectives, worldviews, and experiences as we need to learn them. Cultural and oppression-based knowledge is necessary in therapy, but we cannot possibly learn everything that we need to know in advance. So MCO motivates us to learn what we need to learn when we need to learn it. Starting with cultural humility, as I've mentioned, this is the central organizing construct of MCO, and it has 2 components. The first is interpersonal, being other-oriented, curious, perspective-taking, having a lack of sense of superiority, and an intrapersonal part, and that is having an accurate view of ourselves, particularly our limitations, but this doesn't mean that it's all self-denigration. We need to have an accurate, not just bad or pessimistic view of our limitations as well as our strengths. When we're coming from a place of cultural humility, we understand our own cultural values and beliefs. We take an other-oriented stance. Again, we maintain respect and lack of superiority in all of our interactions. And I emphasize this again because it's so important. It's not a hat that you can, like, take on and off in certain situations. It really is a way of being. And so it's hard to foster and demonstrate cultural humility in our therapy sessions if we're not demonstrating it with students, with clinic staff, with the people at the grocery store. You know, it really is a way of being. And so that way of being includes coming from having a lack of a sense of superiority in our interactions, which is to say kind of an appreciation for all others and humility in all situations, and having a sort of reverence for humanity and community. Being collaborative with each other, expressing curiosity and interest in response to new information, and asking questions rather than making assumptions when we're uncertain. Cultural humility may seem like, hopefully you're listening to that and you're like, yeah, that sounds obvious and important, but it can be more difficult than it seems. It is easiest for us to demonstrate cultural humility when we're more similar to someone else than we are different. And it's hardest to demonstrate when we feel attacked or deficient in some way. And this is where we get into a lot of those like defensive processes and the importance of critical self-compassion. Someone doesn't even necessarily have to say something for us to feel. Sometimes I think as therapists, if we feel like there's a struggle in the dynamic or our clients aren't getting better to the degree or the speed that we think that they should, that alone can cause us to feel deficient. And that means that that alone can be a barrier to demonstrating cultural humility in those moments. It is hardest to demonstrate when we feel deficient in some way, which means we need to be especially attuned to ourselves in those moments. Cultural opportunities are cultural markers that occur in therapy. These can be considered the behavioral expression of cultural humility and cultural comfort. This is a moment of intentional action on the part of the therapist or supervisor to initiate a cultural discussion, to follow the client or supervisee's lead on a cultural topic, or to avoid the entire thing entirely and just move on to a different topic. Davis and colleagues argue that cultural opportunities are always present and that fostering all the pillars of MCO allow us to be better able to recognize them and seize upon them when those opportunities present themselves. So to do that, we have to be able to recognize cultural markers that are indicative of those moments, learn how to craft a variety of messages relevant to intersectional positionality, which basically just means being able to respond and respond well, right? Enhance our understanding of how to frame interventions and interactions around the impact of our own cultural identity on our clients and supervisees. And we can think about these through theoretical frameworks that we already have long had access to. You can think about these cultural opportunities as specific instances of what Tabor and Tabor call points of entry, or what emotion-focused therapy call markers, which is actually exactly what this construct is based on. I also like to point back to Yalom's call for us to develop our rabbit ears for process markers. And so really, when we're talking about developing the ability for cultural opportunities, we're talking about developing those rabbit ears for a specific type of opportunity or a specific type of marker to be able to listen so closely for those things and to respond from a centered and mindful place. This could include responding to or making space for something that's explicitly said. In some ways, those might be the easiest to recognize and to react to. So maybe a student says, as a Black trainee, I find this environment difficult to navigate sometimes. That statement's pretty clear and unambiguous, right? And the fact that I have a choice point is clear to me as a supervisor in that moment. But what happens when that very same trainee just says, I just feel like I don't fully belong? I need to be pretty attuned in order to pick up on the possibilities there, right? To recognize that there might be a part that she's not saying, and the fact that I'm a white woman might be leading to part of why she's not saying it, right? I have to be super attuned to that possibility and create the opportunity to talk about it further. And so that can include, creating an opportunity like that. But creating opportunities can also be addressing current events in an open-ended way, not just making a statement, or facilitating discussion on identity, culture, and oppression. But to do all these things, it requires at least some level of cultural comfort. And cultural comfort refers to our thoughts and feelings that emerge before, during, and after conversations about cultural identities, cultural-focused content, or oppression-related content. So these are feelings of, I like to add relative calm or relative ease, our ability to stay genuinely engaged with others holding different or similar cultural identities, even in the face of differences or over alignment to values or worldview. And so this was like an extra slide on accident, but okay. So the reason that I add this piece about relative calm and relative ease is because I get a lot of questions, especially if I'm teaching students, but not only when I'm teaching students, whenever we're talking about cultural comfort, that boil down to like, how do I skip past everything else to get to that part? Like, how do I be comfortable tomorrow? having these difficult conversations. And the honest answer is that there is no way to do that, right? There is, and we know that as therapists, right? It's just about like porting what we know into this specific context, that there is no developing comfort with something without persisting through the discomfort. There is no learning how to confront conflict without persisting through our discomfort about conflict, and on and on. We have to persist through the discomfort, which means we also have to practice. We have to approach even when we are uncomfortable or anxious, and we have to gradually develop greater and greater comfort. The conversations that I have with clients and with supervisees, students, mentors, anybody at this point in my career are very different than the ones that I started having at the beginning of my career. They were a lot more awkward back then. They're still sometimes awkward now, but a lot less awkward than when I first started, right? Because it's like any other skill, it gets better and smoother with time. And so we have to persist through that discomfort in order to get to that place of cultural comfort. But it's also never going to feel like amazing, right? I shouldn't say never, because I think there's a lot of humanity connecting things that can come from those difficult conversations. But as we'll talk about when we talk about like what needs to be added to MCO, the reality is that when we're talking about culture, we're talking about cultural differences and cultural experiences, a lot of times what we're really meaning to talk about is systems of oppression and their impacts. And that's not kittens and rainbows stuff, right? Those are difficult conversations to have. And very often we are treading into those waters as therapists or as educators from a place of like knowing that maybe us and our client are in very different places. Maybe we're doing group therapy, adding even more dynamics and different positionalities to it. Sometimes teaching is a bit like doing group therapy, so you've got a bit of those same dynamics there. And so this is hard stuff to talk about, like we talked about at the beginning, and we don't always know how these conversations are going to go when we are in a situation where we need to be broaching these conversations. And so that's never going to feel like a day at the spa, right? That's not the level of comfort that we're talking about here. So I think it's really important to recognize that when we are talking about cultural comfort, we are talking about it in the relative sense, feelings of relative calm, relative ease, so that we are ensuring that, going back to intentionality in our language and the importance of addressing things well in therapy, that we aren't conveying incidentally to our client or to our supervisee that this is something that's not okay to talk about, because I'm getting kind of like anxious and clammy and like starting to stumble over myself. And it's clear that I just want this conversation to end as quickly as it can end. When we react that way, we are signaling it is not okay to talk about this with me, or it's not okay to talk about that in here. And so we're just talking about, relative to that, getting to a place of relative calm and relative ease. So cultural comfort helps to facilitate our ability to recognize and create cultural opportunities. Remember when I gave that implicit example and I said I have to be super attuned to the possibilities in that moment to understand that I have a fork in the road and that I need to make a choice about which direction I'm going to go. Am I going to approach this cultural opportunity, or am I going to avoid this cultural opportunity? If I'm uncomfortable and anxious in the first place, it's going to be much harder for me to be attuned to those possibilities, right? So when we do the work to develop greater cultural comfort, greater relative ease, then we're much more likely to feel centered and present and be able to catch those opportunities when they occur and see opportunities to create those conversations. And cultural humility itself helps to facilitate our cultural comfort. If we are kind of the inverse of cultural humility, would be if we are kind of wrapped up on being right, wrapped up in perfectionism, fear of being wrong, fear of looking foolish, all of those really kind of self-focused things, then cultural comfort is not going to come, right? Because part of comfort is recognizing that I'm going to make mistakes and I have to be okay with that, because there is no such thing as perfection, right? So when we can foster greater cultural humility, it helps to facilitate our cultural comfort. And when we are facilitating the development of our cultural comfort, it helps us to create and take advantage of the cultural opportunities. But again, there is no developing that comfort without moving through discomfort. So, in more than 20 studies of over 6,000 psychotherapy clients, nearing at least 10 supervision studies, but I think we're actually at more than that now. We know again and again and again that cultural humility, cultural comfort, and cultural opportunities have been found to have positive effects on psychotherapy process and outcome and clinical supervision process and outcome. This is fantastic. This is the most empirical support that we have had for a model of cultural responsiveness since the movements began. And it is so evident in so many complex ways. We had a study recently of clinical supervision where we looked at the impact of racial microaggressions on supervision and whether cultural humility served as a buffer against the impact of racial microaggressions. And what we found was that basically the supervisory working alliance that the supervisee felt when they were working with a supervisor who they felt was low in cultural humility was just at the floor. Racial microaggressions kind of had no impact because there wasn't a relationship to impact, for lack of a better way of putting it. And so then we saw that for supervisors higher in cultural humility, but who committed racial microaggressions, those microaggressions impacted the relationship negatively, no question. But the whole relationship was still elevated. I'm picturing the graph in my mind. The whole relationship, the supervisory working alliance, was still higher than it was for the supervisors whose supervisees felt they weren't culturally humble. There was still a stronger relationship, even in the context of racial microaggressions. It served as a protective factor. And again, crucially, in the absence or with low cultural humility, there was barely a relationship. For me as a supervisor, sometimes those results like haunt me because we also know from the research that in the absence of a strong supervisory working alliance, supervisees don't tell us things that we need to know, and we can't do our jobs if they don't tell us things that we need to know. And so even from like a self-preservation standpoint, it's so important that we be able to foster a strong supervisory working alliance with our supervisees, because at the end of the day, not only can we not help them develop if we don't know what's going on, we can't protect client care and be helpful to clients if we don't know what's going on. It becomes a liability issue at some point. And so we know that if there's not a strong supervisory working alliance, trainees tend to withhold a lot of important information, the most important things that they should be disclosing to us. And we know that cultural humility is really crucial to the development of that relationship. And so we have so much great research now that makes clear that MCO is so important. Cultural humility specifically is so important in psychotherapy and supervision. But that doesn't mean that the model has been without its criticisms. And the most common criticism has been that there's nothing inherent to the model that moves us toward anti-racism, that compels us toward learning about racism and other systems of oppression, for example. It is implicit in the model that if you're stronger in MCO, you would hopefully learn all the things that you need to learn. But going back to where we sometimes default to, if we're not careful and intentional, sometimes we wind up learning about the things that we feel comfortable learning as opposed to tackling really, really difficult and painful topics. And so the most common criticism, and one that I agree with, even though I'm very much an MCO researcher, is that it doesn't inherently move us toward anti-racism. It has to be MCO plus. And so knowledge and awareness are clearly needed, but given the research that we have on multicultural competence, the way that we've been understanding what knowledge means, what awareness means, hasn't gotten us to where we were trying to go. At least that's what the results of a lot of research would suggest. So how can we better move forward? And this to me is where we get the MCO plus structural competence. Multicultural orientation focuses on the process part of culturally responsive and structurally responsive psychotherapy. Despite the focus on a way of being rather than a way of doing, again, I think this is still very much the skills portion of cultural and structural responsiveness. And that's because a lot of therapeutic and supervisory skill is about a way of being, not necessarily a particular thing that we do, like a worksheet or, a really super special technique, like our two-chair technique or something like that. A lot of our most important skills are about a way of being. Even those advanced skills are built on our way of being. So this has to be combined with expert knowledge and expert awareness, however. So obviously we still need knowledge, we still need awareness, but of what? And some scholars have argued that the way that we tend to define multicultural competence is anti-intersectional. We wind up going down that list of identities, like I was talking about. We have specific boxes that we put people in, and then we learn things about those boxes. Essentialist. And before I even learned or read this criticism in the literature, the first set of people who I heard this criticism from was students over and over again, that they felt as though reading some of the MCC literature actually increased their belief in stereotypes, or their awareness of stereotypes at the very least, because so much of the literature has historically been, here's a bunch of facts about this group that you should know. Here's statistics, here's tend to be true of this group of people, all very stereotype based and all very individual focused. And so scholars in the literature have written about the very same critiques that my students year over year have often brought to me, which is that there's sometimes this essentialist nature unintentionally from the way that we talk about multicultural competence and the way that we teach it. And again, that it is very individual based without looking at those upstream things that cause the downstream problems. So in 2020, Grzenka argued that a stronger approach would be to adopt from medicine Metzl and Hansen's 2014 structural competencies model. So Metzl and Hansen argued that medical education, and I would argue that this is true for psychology education and training as well, has often been misdirected to focus on the individual and cross-cultural understanding. And this is not to say that these things are not important. I'm always tempted to include the Tema Okun's norms of white supremacy, because they pervade our way of professional thinking so often. And one of them is either or thinking. And I'm a big both and person. And so it isn't that there isn't important things that we need to know about cross-cultural understanding, culture itself. And it's not that those things don't come up or aren't important in psychotherapy. They absolutely are. But we need the both and the part that we've often been missing is the focus on social and systemic forces, their historical antecedents, and how those things result in the individual health outcomes that we in our therapy offices or our students' therapy offices seek to treat. So they define structural competence as the trained ability to discern how a host of issues defined clinically as symptoms, attitudes, or diseases, depression, hypertension, obesity, smoking, quote unquote, non-compliance with treatment, trauma, psychosis, how these things also represent the downstream implications of a number of upstream decisions about matters such as healthcare and food delivery systems, zoning laws, urban and rural infrastructures, medicalization, or even the very definitions of illness and health themselves. Two other important definitions that Metzl and Hansen and other colleagues provided in their textbook on structural competencies, and that we also have in our recent TCP article, which I think might be getting dropped in the chat, is structural violence. And this is avoidable harm, things like unmet basic needs, food insecurity, housing insecurity, lack of access to medical care or inadequate healthcare, caused by oppressive systems, so caused by economic, political, legal policy, to individuals and communities that inhibit or even prohibit their ability to reach their human potential. So structural violence is the cause. Structural vulnerability is the consequence. Structural violence is our upstream stuff. Structural vulnerability are the downstream things that we seek to treat. The consequence of structural violence: increased risk of poor individual, family, and community outcomes, depression, anxiety, PTSD, CPTSD, substance abuse, due to the systemic and structural harms, and that cannot be corrected by individual behaviors. I cannot stress this enough. So if it can't be corrected by individual behaviors, what does it have to do with therapy then, right? Especially individual therapy. What are we working with except individual behaviors? This is not saying that there's nothing that we can do at the individual level to support our clients. Indeed, research suggests that critical consciousness raising, helping clients understand how these systems are working, how it helped lead them to where they are now, and what they can do about it in that context, that critical consciousness has very positive mental health impacts. And so that in and of itself is a major target of change through this model. But for many reasons, I am a big fan of the serenity prayer for me from a non-religious standpoint. What are the things that you can control? What are the things that you can't? Let us try to take control of the things that we can and let go of the things that we can't. Now, the let go of things is more complicated in a social justice model, but sometimes in the therapy room, at least in the moment, that's the choice that we have to make, right? Individual behaviors are not going to undo structural vulnerability, but focusing on the things that we can control in the context of the reality of the systems of oppression is where we stand some of the best chance to help our clients in the context of these very real structural situations. And when we can take that frame, then we risk not invalidating people's experiences and helping them feel, for lack of a better way of putting it, a little bit less gaslit about why they're struggling with the things that they're struggling with in the ways that they're struggling with them. Structural competence is rooted in 5 principles. The first is recognizing the structures that shape clinical interactions. So I think about this a lot when I think about my work in community-based settings. In what ways is systemic, structural, and individual racism leading to the fact that a client has been referred to me at all, especially as a testing psychologist? And when youth of color get referred for testing, that needs to be a first question, and we'll come to that more in just a second. And what role did racism play in this referral even happening, the fact that we are having this clinical interaction at all? And in what ways will racism continue to shape the interaction that we're having? Developing an extra clinical, or in our case, non-psychological language of structure, because in structural humility, which we'll get to, psychology doesn't have the answer to everything. Learning to re-articulate what we have so often attributed to cultural presentations in structural terms. Observing and imagining structural intervention, both and developing structural humility, which, as I just alluded to, says that psychology, any one profession, we don't have all the answers to everything. Even things that are psychological problems, a lot of things that have psychological problems have non-psychological causes, right? So we can understand the impact psychologically and what those pathways are from the upstream problem to the downstream problem. But there's a lot of knowledge that we need in between and to intervene with our clients in holistic ways that are not just going to be from psychology. And so we have to have not only individual cultural humility, but structural humility about our profession and our professional training to recognize that everything is interdisciplinary. Gruzenka, in that 2020 article, called for psychologists to consider structural and systemic forces and to employ this structural competencies lens through 3 new questions, as well as one from prior work by case. What role does inequity play in the situation that I'm analyzing or observing? How can I address constructs and systems, not only identities? So, for example, how can I address racism, not only race? How is social power operating in this situation? And what roles can psychologists play in addressing this social problem? What might that look like? These are just a couple of examples of many, many, many that I could give. So, looking at the domain of race, for example, our traditional model might say focus on individual differences, such as, these are things like right from our literature, spirituality is important to Black and African American individuals and communities. Statistically, that might be true, but it might not be true for the individual sitting in front of us, right? Whereas a structural competencies approach would compel us to focus on the structural determinants of client concerns. And with my testing psychologist hat on, things such as de facto segregation, redlining, these things may be like technically illegal now, but we know that de facto segregation exists. And we also know that historical segregation continues to have intergenerational effects. And those have had a deep impact on K through 12 educational experiences and outcomes for people of color, right? So we have to understand how those structural determinants lead to the client concerns that we are seeking to analyze or treat. On the domain of gender, this comes from a real example from way earlier in my life. The idea that a problem in a relationship comes down to like both parties needing to read men are from Mars, women are from Venus, rather than focusing on the problematic gender socialization, institutional sexism and cissexism, violence against trans and gender non-binary individuals, and even the cost of toxic masculinity to men. This approach to therapy is not just for people who are oppressed on any or every domain. This is relevant to all of us and all of our clients. And this last one I always give as an example and a reminder that structural competencies don't just pertain only to clients, but also to trainees. There was a brief mention at the beginning that my research includes looking at racial and socioeconomic inequity in higher education. That includes looking at the student loan debt crisis in psychology and elsewhere, and all of the systemic and structural forces that drive that problem. And so from that perspective, and in that work, I hear a lot of things a lot of the time, such as lower socioeconomic status graduate students just need better financial literacy. I love this for a number of reasons, but not the least being that I am a white person who comes from a lower socioeconomic status background, and I think I had a better handle on the tax code than a lot of my peers when I came into graduate school. When you don't have much and you have to somehow make ends meet, you learn how the systems work, and you learn how to manage things and make a dollar stretch farther than it's supposed to, and better than someone who doesn't have to do those things. Sometimes the math just doesn't add up, right? So rather than problematizing individuals for structural problems, we could instead focus on the cumulative economic, physical, and psychological effects of systemic classism and economic oppression. So this model doesn't just impact or relate to our clinical work, it impacts the way that we deal with a lot of interpersonal conceptualization, including with our students. So what might this look like in practice? Like MCO, structural competence better accounts for intersectionality because we are looking at the upstream systems. And I think it's a little bit easier to imagine how classism and racism and sexism might interact than thinking about a particular person having to occupy multiple boxes. I think things open up a little bit more when we start to think about upstream forces. And so we need to be asking, at what intersection of structural oppression and structural privilege is this particular client or whomever I'm trying to understand or conceptualize situated? So for example, for a Black 11-year-old cisgender heterosexual boy from a lower SES background, instead of merely understanding his identities, we could take the frame of recognizing that he is situated at the intersection of oppressive historic and contemporary racism, classism, and toxic masculinity, and is also influenced in multiple ways by cissexism, heterosexism, and sexism and patriarchy. So this is not a new way of thinking per se. This is essentially a public health model. And whether you are a public health researcher or a medical doctor, if you're going to work in that space, you have to have an upstream understanding of downstream problems, or at least most ideally. And we have multiple examples, contemporary and historic, of how important that lens has been in addressing widespread problems. Remember, at the beginning of this presentation, I started with the fact that a lot of our professional peers, and psychology is in agreement with this, have recognized that racism is a public health problem. And a public health problem requires a public health solution, and all of us working at every level, even with individuals, needing to be able to take that frame and conceptualization, right? And so we have many other examples of how important it has been to take a public health view and a structural view of individual treatment. So the Flint water crisis is one example. One of the ways that I think there were sort of multiple channels happening at the same time, but one of the ways that the Flint water crisis was able to be named as such, and I would say addressed, it's still not addressed, it was the recognition that we have base rates on serious cognitive problems amongst children, and those base rates hold pretty steady. And so when we see pockets of communities where suddenly the base rates are skyrocketing, we can ask, what's going wrong in these households? What are these parents feeding these children? Maybe there's something genetic that's happened, even though that's not how gene pools work. But instead, some astute folks said, well, wait a second, what's going on upstream? Because base rates don't just change like this. There must be something going on. So what is the common thread that connects these children? And we find heavy metals in the water. And so it at least put us on the path of being able to name what the problem is. And even if it's still not addressed, I know that the work goes on today and will inform other work being done, because I have a very depressing map in my cognitive psychology, cognitive assessment psychology course that I always use to show that, like, I know we think of it as like a Flint problem, but if you look at the map of the counties in the United States where the water sources, the public water sources, fail the EPA tests for heavy metals in the water, like lead and copper, not a lot of clear spaces on that map. Um, and so when we can identify a small pocket of a problem as a public health problem, it allows us to better help the individuals who are coming to our attention right there, but it also opens up the apparatus for us to recognize, oh, this is affecting a lot more people than we realized that it was affecting before. And now that we can name the problem, we can actually start to get to work on it, right? Even when we are treating individuals in our office. This again is not new. Physician John Snow in the 1854 London cholera outbreak is a universal story in public health schools. And so for folks who aren't familiar, during the 1854 cholera outbreak, there's actually been quite a number of them, but the 1854 London cholera outbreak, officials approached Dr. John Snow to cure cholera. What can you do what medication, what can be done to treat people at the individual level so that they stop getting sick from cholera and they can get better? And he basically said, I don't have a cure for cholera. I don't know how to do that. But what I can do is trace the source and why it's happening. And so triangulating maps of the outbreak, he found the source was a single water pump in London. You can still visit that water pump to this day, took the handle off, and boom, cholera outbreak stopped, right? Can you imagine if he had been able to pull out an individual treatment for cholera? People would have kept getting sick. Instead, by having to look at the prevention side of things, he was able to stop people from getting sick in the first place. That's the goal, right? And so we have all of these models that show us that a public health approach, when we see individuals struggling, is crucial, helps the people who are struggling, and helps more people long term. I've long said that, if we could solve all the problems and make everyone happy, I'd happily go back to being a waitress. I actually kind of loved that job. So if it meant people are happy and healthy, I would rather us have a happy and healthy world and people are no longer ailing than protect my career. And I maintain that. I want us to get there, to get to a place where we are dealing with both the upstream and downstream problems and working from a prevention model. So what would that look like in psychology? A really important clinical question at the outset is, what's really the presenting problem here? It's not unusual that in the history of my experience that a teacher or a school district through a referral process would say, tell us whether this child has ADHD. Too often this is treated as the presenting problem. The presenting problem is ADHD. The implicit problem is often either we think this child is struggling with executive function, best case scenario, or unfortunately, this child is a nuisance in my classroom. Please tell us why and how to make it stop. And as you'll see in a moment as I walk through the steps of this problem, I don't mean that from a place of denigrating teachers. Teachers are doing way too much with not enough resources and not getting paid nearly enough for it. And so when you overwhelm people, they're going to be desperate, right? And so very often out of a place of desperation and dealing with things that they don't have the time or the resources to handle, a lot of referral questions boil down to this. And so we begin from a structural competence perspective by recognizing the structures that shape clinical interactions. Racism in the education and healthcare systems. What do I represent to this client? If I'm supervising a student and we're both meeting with this family, what do I and my supervisee represent to this client and their family on the basis of race and racism, but also on the basis of other systems of oppression as well? In what ways is structural racism influencing the fact that we are having this clinical encounter at all? Was every child in the classroom identified as a nuisance, or just this child of color, right? And that happens way too often. I see the lack of attention to structural competencies probably the most in the context of ADHD testing and learning disability referrals for assessment. The problem, an avalanche of referrals for youth, usually boys of color, for LD and ADHD assessment. One example being, consider the case of a Black 11-year-old cisgender heterosexual boy from a lower SES background assigned to a supervisee. We're going to talk about that as an example here in a moment. To think about that example and start to case conceptualize beyond just the individual, we need to ask what social determinants are at play. This is that next principle of structural competence, developing an extra clinical, non-psychological language of structure, and also rearticulating cultural presentations in structural terms. What do literatures beyond psychology tell us about these structures and social determinants? So, for example, if we start with a history of redlining, targeted predatory lending, and inhibiting VA benefits for veterans of color, we add to that generations of de facto segregation, even when there have been attempts to legislate this problem away, resulting in segregated, underfunded schools. And part of why I give this example is because where I started my academic career, where I was, also supervising and doing clinical work, that was 2015, and the Department of Justice ordered that parish that year to desegregate because the public school district was formally segregated, not in the sense of like lawful segregation, but in the sense that it was so severely de facto segregated that in 2015, the Department of Justice had to intervene. And so this is not a problem of the past. This is a problem of today. And it's not just that parish, it's not just that state. This is still a pervasive problem. So we know that we have segregated, underfunded schools as a result of this history. That in and of itself results in overcrowded classrooms, overworked and underpaid teachers, and the students who are most likely to be in those overcrowded, overworked classrooms are students of color and lower socioeconomic status students. Add to that a little bit of bias and individual racism, and a child who is experiencing other forms of individual and systemic racism, which is to say racial trauma, other adverse childhood experiences that don't always have anything to do with race, a lot of other things, even aside from just the chain of events that I have laid out for you here. And what you have is a child who is in distress, acting out in school, and teachers who just desperately needed to stop, who, owing to having a large number of students to teach, a lot of papers to grade, not being trained therapists, being tired themselves, just need to get control back of their classroom so that they can, going back to No Child Left Behind, which I can leave out of here, but adds a layer. They have to make sure that they can, especially at a certain grade, have their students pass tests so that the school district doesn't get penalized and they don't get penalized. We've undone some of that at a policy level, but there's still a good bit of it baked into the culture. And so as a result, it's just everyone keep your head down so we can get through, right? And there's no room or time for disruption, no matter how distressed a child is. And so if we look at this list, right, these pieces of this intergenerational and structural case conceptualization, how many of these are really clinical terms? How many of these terms come from psychology? A lot of them don't. They come from the higher education literature, the legal literature. A lot of the adverse childhood experience stuff comes from medical literature, history literature. A lot of these things don't come from psychology, and yet they're crucial to understanding the context of everything that brought that child into my office being referred for learning disability and or ADHD assessment. And how much of this has to do with cultural difference versus racism? How much of this is covered in a traditional multicultural counseling course? My experience teaching these courses is not much, right? And so when we go back to like the case conceptualization research that I've done, and everyone rates themselves super multiculturally competent, but nobody's attending to cultural factors, even just naming race. I don't mean it has to be this stuff, even naming race in those responses. And where is that disconnect coming from? We know that there is a big disconnect between what we're teaching and what we need to know in case conceptualization and treatment. And I think you see some examples of the pieces here of what's needed to fill in that gap. So the next principle of structural competence is to observe and imagine structural intervention. And for all its contention, to me, this is what the social justice advocacy movement has always been asking. And in the context of the rest of the structural competencies model, is it really that far off or far-fetched? Again, think of the Flint water crisis. Like, that requires structural intervention, even as it's having deep impacts on the individuals who are being affected by it, right? To me, social justice advocacy or structural intervention is prevention. And for folks who aren't familiar with the prevention metaphor, we talk about prevention. We often talk about, being downstream of a river and seeing a lot of children floating down the stream, drowning in the water. And so we all dive in and pull them out one by one. And we just keep pulling children out and they just keep coming, right? We can keep doing that. But for one, we're not going to catch everybody. There's just more of them than there are of us. For two, we're going to get tired. And we know that burnout is a huge problem in our profession. So that's like, it's very real. It's not really a metaphor there. It's just a real thing that we contend with. So we're going to miss people. We're going to get tired and it's not going to stop. And so at some point, we have to send at least some of us upstream to go and figure out why these kids are getting in the river in the first place. And sometimes all we need to do is build a fence. And then just like Jon Snow removed that handle from the water pump, we can actually prevent the problem and stop children from drowning in the first place. But if you're not someone who goes upstream, you're someone who stays down and rescues, which is crucial. Does that mean that you don't need to think about what's going on up there and be able to take the information that's being relayed to you about how children are getting there in the first place and integrate it into your understanding? No, of course not. Because when we don't think from that perspective, then it's really easy to slip into, what did you do to get yourself in this river? Why are you here? Why didn't you make better decisions? Why didn't you make better choices? Why didn't you have better financial literacy? Going back to the student debt problem, right? When we don't think conceptually at the structural level, then we tend back toward our individual training. And so even if we are working downstream, which is crucial and life-saving, we still have to be able to think structurally. We have to be able to conceptualize structurally. So again, of course, we have to work at the individual level too, but the essentialist/individual view versus the structural view have very different individual solutions. And this is a both and rather than an either or. We have to foster structural humility. And in this, we appropriately recognize the limits of psychology and psychological interpretations. In this case, to allow for nuanced, complex, and comprehensive interpretations of the case to emerge. So in the example that I gave, case conclusions would include the fact that, and this is sort of like an amalgamation of many, many, many cases I've overseen. The school district is predominantly Black, predominantly lower SES, deeply underfunded. Classrooms are overcrowded. In addition to eliminating gym, music, recess, things that children are actually wired for, they have moved to permanent silent lunch, where you file in, you've got 10 minutes to shove food in your mouth. You get penalized if you make a peep, and then you file right back out to go sit at a desk. High stress families and communities due to other forms of structural racism and structural oppression. Limited belief in and support of students by the predominantly white teachers and administrators, and to some extent, an 11-year-old boy being an 11-year-old boy, especially when we ask them to sit still for 8 hours a day without any relief, any activity, much in the way of peer social interaction, and much in the way of positive interaction in general. Maybe some mood, anxiety, stress-related concerns, adverse childhood experiences, all of which are very important, but no neuropsychological or learning concerns. And the misconceptualization of a case like this is why, despite an estimated 5% base rate, over 50% of school-aged boys, this is like 2013, 2014-ish data. It's probably worse now, given that most pharmacies are out of prescription stimulants. But at that time, over 50% of school-aged boys in Louisiana in some parishes were on prescription stimulants for ADHD. That is a rate that is way out of line with the base rates. But it's because we don't get curious about the executive function symptoms and or whether they're even executive function symptoms at all at times. And instead, we problematize individuals without being curious of what's going on around that child. So I started the structural competencies part by noting that this is a both and. We need the process piece and we need the knowledge and awareness piece. So to me, that is structural competencies plus multicultural orientation. Again, MCO is our cultural humility, cultural comfort, and cultural opportunities. So putting these models together, cultural humility would be recognizing without feeling activated or threatened that, for me personally, I inhabit a very different intersectional position than a lot of my clients and a lot of my students, and that difference means that I may lack knowledge and awareness as it pertains to structural racism, generally and related to any particular case. I have to be willing to seek out the knowledge and awareness I need, and without putting that on my students, my clients, or other people, particularly people from minoritized backgrounds. I need to be willing to go do that digging myself. And as psychologists, that's one of the most important things that we learn. It isn't just memorizing a bunch of facts so that we can pass the class or pass the EPPP. We learn how to learn. We learn how to find the information that we need to find. We know how to do that. And so we have to be willing to seek out the knowledge about systems and structures and policy and social determinants of health and structural determinants of health, and do that work ourselves as we need to learn it, right? Going back to the core principles of MCO, that being strong in MCO motivates us to learn what we need to learn when we need to learn it. And so adding these together, we just need to recognize that a lot of what we need to learn is about social and structural determinants of health and what that means for the individual sitting in front of us. And we have to be open to addressing these things directly. These are not conversations that a lot of us grow up having. Hopefully we learn to address it more openly, start to have these conversations in grad school. But it's not a skill that we often just sort of like immediately come out of high school with, often not even college. And so we really have to be intentional and practice addressing these things directly. Not only gaining the knowledge that we need, but approaching conversations with colleagues, with friends, with mentors, having difficult dialogues about race, racism, systems of oppression, consuming articles, media that can help us develop more in those skills, and then practicing wherever we can, and certainly addressing it directly with our clients and our supervisees, recognizing that we're not going to be able to do it perfectly. Taking cultural opportunities, which I'm alluding to there. If your rabbit ears catch markers of racism related content, follow up on it immediately. Talk about the process between you both. This can be initiating cultural opportunities. So in supervision, for me, for example, what's it like for you to be working with me, a white woman? If we're working on that previous case, I was just, that example case I was talking about, what's it like to work with me, a white woman, on a case like this where racism is so central to the presenting problem? Do you feel like you can talk about racism in here, whether it's about your clients or even your own experiences? What would help our supervision to feel more supportive in that way? What can I do? And what is it like for you, if I'm working with a Black woman supervisee, to be working with this child, to read the BASC-3 teacher rating forms from the white teachers that just say this child is a problem all the way down the board, when we don't necessarily get the same ratings from parents, other community members, even if we're fortunate enough to have a Black teacher in the mix, those ratings often look very different, right? So what's the experience like of having to read these forms? Because that in and of itself is hard. That in and of itself is hurtful. And we have to be able to help our trainees through that piece as well. Or if you are that person reading those BASC-3 rating forms, seeking support from trusted people, because it is hard to read those things and see it for what it is. These things are all a lot easier to do when it is simply how we conduct ourselves. Again, this is a way of being. It's not a card that we whip out of our pocket in a specific type of circumstance. We need to integrate cultural humility, cultural comfort, having cultural and oppression related conversations into our way of being inside the therapy room and out. And when we do that, it gets a lot easier to do it in each specific context. And folks tend to know when it feels less like just sort of like how you conduct yourself and more like something you feel like you have to do, you know? And so because I think there is so much of this that's like, it either fits with your values and your way of being in some ways, or it doesn't. I think for most psychologists, it fits for us, but all to say that it's something that you can't really fake. And so if it doesn't fit, then that's going to be tough. But if you're like most psychologists, I think, and the desire to adopt this way of being is there, it's just like the practice part of it, then that's the thing, is we just simply have to practice it. We have to work intentionally to integrate it into our way of being. And that's really hard because we're not just doing that on neutral territory. We're doing it against a lot of pressures that actively keep us from being like mindful and in the moment. I made a comment about the burnout in the mental health professions. I sometimes give talks specifically on burnout in the mental health professions. And the research is so incredibly clear, not only that burnout is super prevalent, but that, like everything else we're talking about, the primary causes of burnout in the mental health professions are systemic and structural. And whenever we try to implement individual solutions for burnout, like a mindfulness day or something like that, they don't work. You might get a reduction in symptomology for like a week or two, but then everything goes right back to the way that it was because everything that's going on upstream is still happening. And so that is the context most of us are operating in when we are trying to approach therapy in this way. So kind of what I'm asking from you is to be super present, super mindful, keep your rabbit ears attuned. But when it's just client after client after client after client, hour after hour, and then paperwork and dealing with, if you're a supervisor, this supervision issue that comes up, and then billing, if you have to deal with billing, or at least if billing problems come up, or you need to deal with this administrative issue or this interpersonal thing between colleagues or whatever it is. It's not like we have a lot of free time and free headspace in our profession currently to be super intentional easily about adopting this kind of way of being. Our culture is oriented toward faster, 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 more, 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 go, go, go. And that is directly at odds with trying to foster these qualities. That is a real challenge. And that is one that I desperately wish I had the answer for you. Like, here's the magic solution to this intractable problem. And once you use this key and unlock the door, everything just becomes amazing and easy. And, suddenly you will adopt these qualities in all situations. I wish that I had that particular answer. I don't, but I do know that we have to somehow foster these qualities: cultural humility, cultural comfort, cultural opportunities, practice integrating them into the way that we approach everything, learn the structural competencies, knowledge, and pair that with MCO, that we have to engage in those processes with intentionality somehow, despite those upstream forces, if we want the better outcomes with our clients, with our supervisees, if we want to make sure that we are attending to the process with them as best we can based on what we know from the empirical literature. So I say that to say that I know it's challenging. I really do. And I'm certainly not always perfect at it as a result. But it's so important that we continue to try and we continue to engage with intentionality. Cultural comfort, we have to be not only willing to do that hard work, willing to do it despite all the systemic and structural pressures, but to be able to do so with an internal sense of and demonstrated ease. Again, this takes time and tolerance of discomfort, which sometimes is where the work has to begin, is that tolerance of discomfort. And related to that is the tolerance of imperfection. Something I meant to mention on the cultural opportunities slide a couple slides back is that I often hear from folks this worry that well, what if I take the implicit example, right? I just feel like I don't fully belong here that I gave earlier. What if I introduce the possibility that it's racism related and I'm wrong, right? What if I'm the one that brings up race in the conversation, racism in the conversation, sexism, heterosexism, and that doesn't fit for the client? And now I've made a huge mistake, right? My experience has been that fear is pretty universal, but the research doesn't bear it out. And certainly my own clinical experience and supervision experience doesn't bear that out. Typically, if people feel like something doesn't fit for them, as long as we're approaching from both a genuine perspective and coming from a place of humility, and we're not forceful about it, then folks will usually say, no, that's not it, or it doesn't fit for me, and they move on. It's that part is usually a much bigger deal to us than it is to them. But what we find again and again in the research, I see this in the supervision research to a huge degree, is that when we ask supervisees of color, and supervisees in general, but also specifically in samples of supervisees of color, what was the most helpful thing in supervision when it comes to things related to culture and what was the most harmful thing over and over and over and over again. The most helpful thing is my supervisor talked about it, initiated conversations about it. And the most harmful thing was they didn't talk about it. They didn't initiate conversations about it. So our worry about bringing it up when it's not relevant is usually way overblown as compared to the extent that we should be worried about not bringing it up. And so again, as long as we're not forceful with it, and cultural comfort helps hugely with this. If we're more at ease, it's a little bit easier to present things tentatively. Like I don't know if this really fits, but I can't help but wonder if, when you say, I just don't belong here, if you feel like race and racism is a part of why you're feeling that way in this predominantly white program or working with me as a white supervisor. When we can couch it with tentativeness and just say, I don't know if this is what's happening, but I wonder. And it's much more likely to land better. And it's easier to come from that place when we are more tolerant of discomfort and ambiguity, and when we are coming from that place of demonstrated ease. So we have, well, here's my thank you slide. So thank you for your time and for listening today. I know that I'm running a little bit early, but we've got some time for Q&A. And so we'll pull up our Q&A box, but also
Hi,
encourage
Dr.
folks to
Wilcox,
drop in more
John
questions.
Davis, and if someone will turn on my video. We've had a lot of interesting comments and questions during your presentation. Thanks very much. Let me send a couple your way, and we can, as you said, we've got a bit of time to address them. So one question came on early on. I appreciate you noting the misconceptions that come with the word privilege, especially in today's political climate. That word seems to provoke defensiveness and causes some people to automatically stop listening. The fear of something being taken away does the same thing. I wonder if more people would be willing to actually hear the messages if we use different terminology.
Yeah, that's a really great question. And I also want to note that even though I'm running early, I saw that there were like 23 questions in the Q&A. So I was like, I think we're going to be okay if I run a little bit early here. I'm just going to move on. I'm so glad that folks are engaging on this. And this first question is a great one. And I feel really torn about the answer because on the one hand, I think it's really important that we be able to talk about privilege, but help people understand what we're really trying to say versus what's often invoked for people when it comes up. But I also know that like a part of my work, and which is grounded in critical theory, and critical theory sort of says that, to put it briefly, once we've lost a narrative, we're not going to get it back. And so, once something has become popularized and misunderstood, that no matter how many times we try to correct the record, no matter how many times we try to wrestle the narrative back, that we're not likely to be successful in that. And I've had some people ask in the past, for example, how is in some ways structural competence any different than what feminist psychology was talking about in the 60s and 70s? And my answer is often like, it's not really actually super different. It's just that like we're not going to rescue back some of the tropes that that got misassigned to it, and so we need to update our language to help people hear it. And so I think big both and person, and I guess that's ultimately where I am, is that like we're possible. I think we need to be able to try to talk about privilege for what it is, but if an audience or a person seems so wrapped up in the terminology and we've lost the narrative, then I think we have to update our language and our terminology, because critical theory would suggest, and we see this again and again in history, that we're not going to get it back. And so we have to frame things in a way that people can hear it.
Okay, thank you. Let's see, another question was, again, kind of a terminology question. Could we reframe culture as United States societal culture, since that is the primary direct influence? What are your thoughts about that, the term culture and US culture?
That's also a good question, but I think You know, the way that the term has often been used in the literature, and part of this goes back to like, we're not going to shift a narrative, and part of it goes to like, this piece does have its importance. A lot of the literature is focused on intercultural or cross-cultural understanding, right? So if I'm working with someone who immigrated from another culture, for example, there are genuinely values and customs and things like that that I want to make sure that I understand so that I'm not over pathologizing my client, so that I'm not saying or doing things that are offensive, so that I'm not missing things that might be concerning because I'm writing it off as a cultural difference. So under pathologizing. So there is an intercultural difference part that's important. And I think we need to have the appropriate boundaries around that as a construct and then be able to talk about oppression-based things separately. If I understand the spirit of your question, the thing that I think is closest is something that I made a very brief reference to, which is Tema Okun's norms of white supremacy culture, which are basically the norms of United States culture: perfectionism, productivity, quantity over quality. Progress has to be more, 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 and bigger, as opposed to better. Going back to the quality thing. Either or thinking, all that kind of stuff is kind of US culture. And so I think, talking about it in that way of like white norms of white supremacy culture helps us understand that it's harmful, helps us understand that it's baked into a lot of our systems and structures. And also helps us honor the scholars of color who have helped to develop those ideas, because that's another great example of a scholar of color gifting us very clear language about a very serious problem. And so I think honoring that language is really important.
Okay, thanks. Another question about couples therapy. Do you have any thoughts on how we can provide culturally and structurally responsive care to couples? Most of my clients are couples, many who are people of color, and most of the leaders in the couples therapy field are white, straight, cisgender males. I worry about what we are missing.
Me too. And I love this question. I do couples therapy. I love couples therapy. Um, and indeed, in terms of like who the literature leaders are and everything like that. Um, I don't have a pithy answer. That could be its own CEU workshop, I think. Um, but I think most of what I can say is that it's just so incredibly important in the couples therapy context and requires sometimes extra care, because kind of like when I was talking about doing group therapy or even teaching a class, obviously in those situations, people are going to be in very different zones of proximal development. And as it pertains to culture, but especially things related to the systems of oppression that I've talked about today, my own experience has been that sometimes the very things that bring people into couples therapy related to those issues is being in different zones of proximal development on these issues. And so, being in different zones of proximal development, different levels of critical consciousness on issues of sexism, cissexism, heterosexism, racism, capitalism, and not being able to hear each other from those different positionalities, and not really being able to, because they're in the thick of it, right? Not being able to realize the systemic and structural forces that are acting on each of them and them as a unit. And so it becomes ever more important to be able to recognize that process happening in couples therapy or in relationship therapy, because it isn't just couples. But also to tread carefully, like have your rabbit ears super attuned both to the cultural opportunities and to the potential landmines, so that you can try to engage in that critical consciousness raising really carefully, recognizing where everyone's at zone of proximal development wise. I think there's a lot of different things that are really important to learn and attend to at the intersection of the things we've talked about today, and couples therapy could easily be its own workshop. But I think the most important thing is recognizing that critical consciousness and zone of proximal development and where they may differ, and be able to recognize that as part of the influence on the presenting problem, but also a place where we have to plot our path very carefully as the therapist in that dynamic.
Okay, great. There's another question that came up. There is some research suggesting that as people age, they become increasingly conservative, both politically and economically. Our profession as a whole is aging. In light of that, what might we do as a discipline to ensure that our senior clinicians and researchers remain attuned to the importance of cultural humility, cultural comfort, and cultural opportunities?
Yeah, I think that is the importance of cross-sectional or longitudinal versus cross-sectional research, right? Is it that that people over time get more politically and economically conservative, um, and in the longitudinal change sense, or is it that there are cohort differences in those things because we experience very different policies and structures? What's funny to me about the question, which I think is an important one, is this is exactly what I was writing my fellows talk about earlier today. And I talk about the fact that my parents come from rural Appalachia. I'm unusual. I'm a millennial progeny of the silent generation. My parents were born in the 30s and 40s. They're gone now, and the stereotype is what was just what was just described, but up until the very end of their lives, they were deeply, deeply liberal, and nothing was going to shift them from that. Union workers, labor organizers, social workers, and so for one, sometimes one picture isn't always everybody. But I think about what my parents experienced in the silent generation versus the generations that came after them that maybe had different trends. My dad was a Vietnam War vet. And so he had a very different view of, like, very different mistrust in systems than some of the generations that came after him, who also had very different economic lives as a result. And so this is where I think the structural competence part becomes so important. Like, we have to understand the historical trends, the policy trends, be able to connect to the cause and the effect. Because I think when people don't, then it's easy to shift into individual blame. And I really think that's where a lot of that, like, protection of resources comes in, is, oh, well, it's individuals have control over these things. So for one, I'm going to protect everything I can because that's within my control. You'd think the housing market busts again and again would show that that's just simply not the case, that all of us are more precarious than we would like to think. But that also, other people have individual control over their lives. And so therefore they should just make better choices. The, graduate students just need better financial literacy thing. Once we start to provide education on the connection between decades of policy and what we're seeing on the ground, I think then people start to recognize that things aren't as individually determined as they thought. And that opens up a whole world of possibilities in terms of how we can all work together to lift each other up. And so I see some of those trends. Like, as much as I'm trying to, like, debunk the trend, I do see it in our profession. It's not that I don't see it. But I think some of it's cohort differences. And I think there's some research to back that up. And to me, it speaks to the importance of the structural, like the historical knowledge part of structural competence, and making sure that we all have it so that we can accurately case conceptualize the things that we're seeing, which might sometimes be client problems, but they might sometimes be a professional guild problem that we need to conceptualize from that lens.
I think we have time for maybe one more question and a comment. This is kind of related, but this individual wrote, working in a hospital, I can provide these kinds of formulations to be reflective of the patient's experiences. A common critique I get, though, from other members of a multidisciplinary team is, this is not helpful. We can't do anything with this. How can I advocate for this perspective as being necessary and useful?
Yeah. Oh, I'm going to get the website wrong, but it's something like structuralcompetency.org, I think. If you Google structural competency group or something like that, it should come up. And, remember, that movement comes from medical education, not unlike the original cultural humility literature, right? Pockets of medicine have often been far ahead of us. And I think it's because medicine is often like the frontmost line workers when it comes to dealing with the downstream problems. And on that website is a textbook that is available, like, open domain, but it's a real Springer published textbook on the structural competency model in medical education and mental health. And the chapters in that book are so incredibly helpful to answering that question, as well as providing like, look, as I like to say, like, this isn't Mel's crazy idea. This is like a bona fide thing that, like, you know, other scholars have put together on the basis of people who are working with real patients, right? Um, and so I think like that's also the importance of this work, like the research and the textbooks and things like that, is it legitimizes the work. It gives us resources to take back to our colleagues and say, look, this is a real approach, and there are real things that we can do. Because here's the thing, like going to the hospital part, right? And even as I'm saying this, it's clear to me that like my own experience with my family has influenced so much of my thinking. Like, yes, if you have someone who is coming in to an ER with both like anxiety and a diabetic episode, you know, their blood pressure, their blood sugar is really high. They, you know, didn't get it under control. And so, you know, that's also spiked their anxiety. And now they are both in crisis and, you know, having this blood sugar episode. Yeah, like understanding the policy piece isn't going to reduce their anxiety in the moment, isn't going to reduce their blood sugar in the moment, but it can help us make sure they don't have to come back again next week, right? There are things that we can do, recognizing the next layers out, to try to get them the supports that they need so that we can help get them on a better path. And a lot of the like the case conceptualizations I used in both in this PowerPoint and the one that we use in the article in the Counseling Psychologist are based on the case conceptualization framework that is provided in that textbook. And I think the example that they give as the starting point is somebody presenting to the emergency room, if I recall right. So that is an incredible resource, the textbook and the website itself. And I can't recommend it enough for more examples, as well as more information to take to colleagues like, hey, this is an approach to practice.
Excellent, excellent. Well, Dr. Bocox, thank you for this very thoughtful presentation that, you know, as you focused on earlier, uses the words. I'd just like to share that there were several comments in the Q&A, as you'll see, speaking to the very meaningful, personal and professional nature of your presentation. I'll read one briefly. Thank you for your presentation. As a person of color, I deeply appreciated your emphasis on cultural competency and humility as a way of living, extending beyond academic and professional settings. I have often felt that efforts to promote multiculturalism and anti-racism can sometimes appear forced or hypocritical. Despite these efforts, micro and macro racism persists in our everyday interactions with colleagues and within the broader culture of our institutions. Your approach resonates with me and highlights the need for genuine and sustained commitment to these values. I thought that was a great comment. I wanted to share it with everybody.
Yeah, thought webinar presenters weren't supposed to cry. Like that's kind of, what a way to end today. Thank you.